Hello, all. Welcome to this week's image evaluation series. This week, we're going to talk about the ankle. Last week, we talked about the foot, and we're just going to kind of move up the leg here. We're going to talk about the ankle. So, the ankle involves three different views an AP, an oblique, usually a Mortise oblique, which is a little bit shallower oblique, about 10 degrees, 10 to 15 degrees, medial oblique, and a lateral. Now, the most important thing about ankles is making sure that foot is dorsiflexed and that your collimation is nice and tight and that you're not including a bunch of stuff that you don't need to include. So let's talk about that. We'll be using the same PACEMAN acronym to go through these images and let you guys know what you need to be seeing on your ankle x-rays. Let's get started. Let's start with the AP. Okay, here we've got an AP ankle. Area wise, position wise, we're looking pretty good. I don't see any rotation. You can see the talar dome there is pretty open. The mortise joint. If you start having some problems with rotation or something, you're going to have some superimposition down here on the medial malleolus over the talus, or the other way, we're going to have some superimposition with the distal fibula over the talus as well. But I don't see any rotation to speak of on this one. Area wise, we've included everything we need to include. Okay, so the important part that we need to include on an ankle is, of course, the ankle joint itself. Okay, here we've gone down into the proximal row of metatarsals, which is okay. We've included, a third to half of the tibia and fibula, which we could be closed down a little bit right there. But area-wise, we've included what we need to include. Collimation speaking, we've collimated really well, actually. And like I said before, we could maybe not see as much tib fib, but not the end of the world. I would never redo this image. It's actually collimated pretty nicely. Laterally and medially, it's perfect. We can see a collimation line right here and a collimation line right here. It's really nice. Exposure, it's a nice image. Very little noise. We've got good distinction between soft tissue and bone, which is nice. We can see bone texture or cortical really well. Joint spaces are well developed here. Note that we do have some superimposition on the lateral side of the tibia with the medial side of the fibula right here, which is normal. Okay, that's what you want to see on an AP. We've got a good joint line between the medial malleolus and the talus. We do have a joint line between the fibula and the talus as well. We're going to open that up a little bit when we shoot our Mortise view. But exposure-wise, we're in good shape. We do have a marker. We know it's right. It's placed correctly. I like to place my markers on the lateral side of the joint that I'm shooting. So it's perfect placement. Aesthetics, I don't see any artifacts to speak of. We do see a little bit of a indentation here where the patient's sock maybe lies. There's a little bit of indentation there, but that's okay. We can see a little bit of dark coming across right there. It would have been advantageous to maybe take the patient's sock off at that point, but again, I wouldn't redo it for that. That's just something you need to think of beforehand. But yeah, as far as AP ankles goes, this is nice. It's aesthetically pleasing. So let's go on to the Mortise oblique. Now let me explain the difference between a Mortise oblique and a regular oblique. For our protocol, we use a Mortise oblique, which is a 10 to 15 degree medial angle of the ankle. Okay. And we'll get down here to a regular oblique, which is right here, I believe. Nope, that's the Mortise. go down here. This is a regular. You'll note that the joint line, the mortise joint line, is completely obliterated. We can see the talar dome right here, and we can see the tibial-talar joint fairly well. But as far as the talar tibial joint right here on the lateral or on the medial side, and the fibular talar joint, talar fibular joint on the lateral side, those are both closed. Okay, and that is a 45-degree angle. The only thing that's created there is we're a little bit more open between the distal fibula and tibia right here. Okay, so let's go back up to the mortise view, which is the shallow oblique. Note that our mortise view is nice and clean and open. Okay, we've got a really nice joint line between the fibula and the talus right here. Our talar dome is very well seen. Okay, that joint line between the talus and the fibula or the tibia is nice and open, as is the medial talar fibular tibial-talar joint right here. Holy cow. Sorry, guys. Anyway, this is a mortise view. This is what you're looking at. You want that talus to be nice and seen in profile there, and the joint lines that fall along with it need to be open. Okay, this is a nice mortise view. I don't see any rotation there. The area that we need to see is perfectly demonstrated here. It's very nice. So the collimation is basically perfect. This is the type of collimation you want to see on an angle. You don't want to see the entire leg plus the entire foot. Remember, we're collimating to the ankle, so we need to see the ankle joint itself. And the more we can collimate, the clearer we're going to see that picture. Okay. Exposure-wise, it's a nice exposure. I don't see any noise. Joint spaces are well defined. Bony cortical the cortical of the bone and the periosteum we can see really, really well. The texture is really, really nice. A nice difference between soft tissue and bone. Nice sharp edges. This is a very nice mortise view. Aesthetically speaking, I don't see any artifacts or anything of that nature. There is a fair amount of arthritis in this joint, noted by the light outlines. You'll note that on especially the fibula right here, we've got some wavy edges to the bone that can indicate some arthritis or some age or anything like that. So we've got a right marker. It's placed in the correct position on the lateral side of the affected joint. And aesthetics, and like I say, I don't see any artifacts at all. It's a nice picture. So here we got the lateral. Okay, this is actually a nice lateral as well. Position-wise, we're able to see the joint line, the talar tibial joint line right here really quite well. It's a nice half moon. If you start seeing that look a little squirrely, overlap where you don't need to overlap, that's where you're going to start seeing some rotation. But here we have very, very little rotation. And you'll note that the fibula is superimposed behind the tibia in the posterior portion of the tibia, which is what we need to see. If you start seeing the fibula back here behind the tibia, you'll know that you're over rotated. Okay, and you'll need to back that off a little bit. If you see the fibula up here in front, you know you're under rotated. So just keep that in mind. Collimation wise, it's beautiful. We have included a little more down here than we probably need to, but beautiful, beautiful job. You'll note that the marker is slightly in the anatomy right here. We need to be careful with that. Make sure that marker is up here a little bit higher and in front of the ankle joint. You'll also note that the foot is nice and dorsiflexed. Dorsiflexed means that the foot is actually modeled up. So you're making a 90-degree angle with the foot and the lower leg. That helps open things up a little bit. We can see a little bit of the sinus tarsi right here. If you can have a see-through tarsi, that's a pretty good image. It's a space here between the inferior talus and the superior calcaneus right there. We've got a marker up front there. It's no artifacts that I can see. We've included plenty of the forefoot right here, which is great. So, yeah, nice picture. So we've already kind of looked at the 45-degree oblique of the ankle. Like I say, you're really closing off the the mortise joint like that one. You can see a nice difference between the mortise joint here and the mortise joint here. Okay, but you'll see a difference. We're somewhat open here between the fibula and the tibia. Okay, down here we're open, which is a nice picture of that. However, collimation on this is pretty good. We've probably included a little bit more of the tibia and fibula that we need to. It's marked correctly. The exposure is nice. So this is a good oblique. Okay. But as far as protocol goes, I'm of the opinion, and I've spoke to providers about this, they like the mortise joint, just so they can see that talar dome really, really nice and see if there's any disruption in that at all. Sometimes talar fractures are hard to detect, and this is a good picture for that. Okay. But that's what we need to see on an ankle, guys. Nice tight collimation. Like I say, we don't need to see the entire leg up to the knee, and we don't need to see the entire foot. Just make sure you're collimating tightly to the actual ankle joint, and you'll be in good shape. Just pay close attention to your positioning. Make sure you're not over or under rotating. With the mortise, you're only going about 10 degrees. 10 to 15 degrees, where the regular oblique, you're going the full 40 to 45 degrees. Just keep in mind that protocol is usually the mortise view. So I just kind of threw this one in. Ankle injuries are very interesting. I've seen a few of these in my career. Here we've got an anterior dislocation of the distal tibia and fibula. It's completely off the talar dome right there, sitting anterior up here. Looks like a pretty miserable image. I think that as far as the providers go, it's fairly easy to get back into place, but it does take some work, and it's a lot of discomfort for the patient. Here's the AP view of that. And again, this shows why we take different views. If we were just to take the AP view of this ankle, we would know something's going on there. We know that our mortise joint is really out of whack. We've got some superimposition with the talar dome and the distal tibia, and the fibula is actually superimposed over the talus. So we know that something is going on there. Until we take the lateral, we know that, wow, that's a big time anterior dislocation. On this, you really can't tell. So take every picture, every projection you need to take for each body part that you x-ray. Okay, very important. Anyway, I hope this was helpful. Just remember, we're collimating to the ankle joint. Make sure your markers are on the lateral side of the affected joint and on the lateral on the anterior portion. Okay, you guys are doing a great job. I love looking at your x-rays. I've seen a marked improvement. So great job. Keep up the hard work. Next week, I think we'll look at the tib fib. Tib fibs can be a little tough to take, to expose, just for the fact that it's a longer bone. It's hard to fit the bone on one film, so you usually have to take two. But enjoy the rest of your week. Happy October to everybody. It's the best month of the year, besides September maybe. Yeah, have a good week. We'll talk to you guys soon. See ya.